Welcome to the inaugural session of Primary Care Matters. I'm Sue Bornstein. I'm the Executive Director of the Texas Medical Home Initiative and co-lead of the Texas Primary Care Consortium. The Texas Primary Care Consortium is the only statewide collaborative with a mission to advance high-quality primary care for all Texans. It is co-led by the Texas Health Institute and the Texas Medical Home Initiative. The purpose of Primary Care Matters is to take a deep dive into topics that impact the provision of high-quality primary care in Texas and beyond. Today, we are honored to have Julie Schilz as our guest. Julie is a thought leader and keen observer of primary care, who's been on the forefront of the development and rollout of a number of primary care models nationally for the last 15 years. Julie, a nurse by training, is currently the Senior Director of Consulting and Training at the Primary Care Development Corporation. Julie, welcome. Please tell us a little bit about yourself, including about your present position, and share with us how you became involved in primary care.
Well, thank you so much, Sue. It's really great to be here. You and I have worked together for many years, and just to be able to have this conversation about a topic that we are both passionate and spend every day working on. So I'm Julie Schilz. I'm with Primary Care Development Corporation, as Sue mentioned. And Primary Care Development Corporation is a nonprofit organization. We've been around for 30 years now. And our initial work started as a community development financial institution. So providing capital lending to federally qualified healthcare centers and to behavioral health organizations, particularly those who are in communities that have the greatest need. We also provide advocacy, especially around primary care and behavioral health. We do this both locally, where we are based in New York, as well as nationally. Also providing support for evaluations around subjects related to primary care. But as Sue mentioned, I'm part of the consulting and training team and have the opportunity to work with FQHCs, public health organizations, behavioral health organizations, communities all across the country, helping them as they look to deliver high value primary care or integrated care delivery. So how did I get here? What led me to a love of primary care and truly a passion of supporting it in our healthcare delivery system? As a nurse, I was a former pediatric nurse, working in neonatal intensive care. And for those kids with those significant medical needs, primary care was such a critical component in their ability to leave the hospital and lead a full life. So that's where I started my journey personally of understanding how important primary care is in our community. I also had the opportunity to work at a daycare center that had children with medical needs in it, and again, primary care was so important. So that started me on that path and that passion that I've had for the rest of my career.
Wonderful, wonderful. It has been really a delight to work with you all these years. So now we want to turn and start to really lay the groundwork for the conversation that Julie and I are going to have. I need to share some data, and it's not all good data. It's about primary care. So just to start, I do think it's important that if we're talking about a topic, we need to all have a common understanding of what that topic really is and what it means. So I'm going to quote from the 2022 report on primary care from the National Academies of Science, Engineering, and Medicine, also known as NASEM. NASEM has done several reports on primary care over the last 20 or so years. I think that they have really hit on a very good and very useful and durable definition of primary care. So they define high quality, and we are talking about high quality primary care, as the provision of whole person, integrated, accessible, and equitable health care by interprofessional teams who are accountable for addressing the majority of an individual's health and wellness needs across settings and through sustained relationships. I have read this quote many, many, many times, and when I read it, there are a couple of things that really stand out to me that I would underline essentially, and that is accessible. One of the things we're going to talk about today is that there are the challenges with access to primary care. Interprofessional teams, this is key. We can no longer have solely the physician delivering primary care. Not only is it not feasible, but it's really not even desirable. Interprofessional teams bring everyone has their own skill set, and in my opinion, strengthens the team. And the third one is the sustained relationships. And in my view, this is really the secret sauce of primary care. This is how primary care works under the best circumstances. So now we know what primary care is. Why primary care? What does it do? Well, a couple of things that we've known for a long time. High quality primary care is the foundation of a high functioning healthcare system. And we look at countries to whom we compare ourselves in terms of health care and health outcomes. And it is very clear that more is better in primary care. Also, primary care is the only healthcare component where increased supply is associated with better population health and more equitable outcomes. And we will talk about equity because this is crucial to primary care. And finally, and I find this a very compelling statement, we need to think about primary care as a common good. And what does that mean? Well, to me, it means something like having clean water. If we live in a community, we expect that we're going to have clean water, public safety availability. And I think we need to put primary care up in that same category. It is a common good. So now that we know what it is and why it's important, we need to turn to what we know about what is not working. And so the Milbank Memorial Fund, if you all are not familiar with them, I would strongly encourage you to look them up and follow them. They do excellent work as far as about primary care and a lot of other health related issues. But they publish an annual scorecard on the health of primary care in the US. And spoiler alert, this year's is entitled The Cost of Neglect. And so here are some of the main problems identified in the report. This is not, by no means, this is all inclusive, but these are things that we can start discussing. Financing. We talk about this all the time. Primary care is under-resourced, has been under-resourced, under-investment probably since the beginning. About 5 cents of every dollar in this country, healthcare spending-wise, goes to primary care. Yet, primary care provides more than 30% of physician visits. And so there really is a mismatch. We are seeing movement in some states where states have been able to increase their state related spending on healthcare over a period of time. But 5 cents on the dollar is really not adequate. And so that sort of bleeds into workforce and access. If we don't have funding, our primary care workforce is diminishing. And that this is a complex topic. There are a lot of factors involved, but it does affect access to care. Another important topic is training. We know that graduate medical education funding was really essentially capped in the 1960s, whereas certainly our population has continued to grow and continue to age. And so we just don't have the funding to produce enough primary care physicians in this country. And also, another important topic that the NASM report focused on was training people where they live. In other words, many clinicians, myself included, were trained in the hospital setting, and that's important. More important for some specialties than others. But I would say 90% of my medical training was in hospital, whereas I walked out the hospital, finished residency, and went into a private practice. And so there's really a mismatch between the skill sets that are required in the hospital and what is needed in primary care. So things like federally qualified health centers, community health centers, training in those types of environments is really crucial. Another thing is electronic health records. Probably can't find a whole lot of people that would raise their hand and really say how great they are. In my opinion, and in the opinion of many others, they do not really advance quality care. But what they do is they increase frustration and burnout and moral injury among clinicians. We need to do better in technology. And ultimately, and this is, I think, very pointed now and important now, lack of research. Julie has been involved in studying different models of primary care. Well, the two of the main models in the Center for Medicare and Medicaid Innovation, primary care, big national models have been put on hold. This is very concerning as far as our ability to understand and affect improvement in primary care. So finally, I do think that we need to talk about a little Texas-specific data. And I think all of us know that we lead the nation in uninsured. 20%, 18 to 20% or so of Texans are uninsured. And what is that? Well, it does a lot of things, but one of the things it does is it really inhibits people from accessing primary care. And thus they tend to access care in places where it is more costly and not necessarily appropriate. We also know that the uninsured rate is not equally distributed. Again, when we talk about health equity, close to 30% of our Hispanic Texas residents are uninsured. And along the Texas-Mexico border, it can be up to 30%. Another factor, very important factor, that I do think is getting more recognition of late is rural Texas. We have almost 3 million Texans live in rural areas. And why is that important? It's important because they are generally older, they're generally less well-resourced, and they tend to suffer from more chronic illnesses. And interestingly, the clinicians that care for them tend to be older as well. And so what does that all do? Well, we have higher hospitalization rates for preventable conditions in the state. And something that has gained a lot of attention and a lot of thought is, how do we resolve our shortage of primary care doctors? We are 48th in this country in the ratio of primary care physicians to our residents. And 32 of 254 counties in Texas have no primary care physician at all. So I like to say, as an internal medicine physician, this is not a diagnostic dilemma. We know what the problems are. What we need to do is to have the resolve and the willingness and the support to address those. So Julie, I've painted a kind of a bleak picture here of primary care in this country. And so we would love to hear your thoughts on what is working in primary care these days.
Well, thank you, Sue. And I think there's a reality that there's still work to do, and I appreciate the foundation that you laid for our conversation today. All incredibly relevant points. Before I get started on what's working, just want to thank the Primary Care Consortium, as well as the Texas Health Institute and the Texas Medical Home Initiative. I think the work you're doing is one of the reasons why we will be able to tackle some of these really tough issues. But thinking about what's working, and you started with it, we do have research. We do have research that says primary care is effective in creating a healthcare delivery system that focuses on health and prevention. You mentioned the most recent NASM report, critical work that is really helping to guide where we're at now in thinking about some of the solutions and the problem solving. But additionally, we have historical research, Barbara Starfield being one of them, who really grounded us all in the idea that primary care needs to be a key component of our healthcare delivery system in order for us to achieve health. Focusing on prevention, wellness, management of chronic disease. Barbara spoke to the 4 C's that we tend to refer to, that first contact. Primary care being that first contact for patients to really support those health outcomes. Thinking about comprehensiveness. primary care addressing a broad range of healthcare concerns, including preventative care, acute care, chronic conditions, mental health conditions, and even in some cases, non-medical determinants of health now. Continuity, having that long-term relationship so you can really focus on having a relationship with patients. The team within the primary care practice can have a relationship with patients. The patient is at, and families and community are at the center of those of the care, really allowing for that longitudinal, long-term relationship. Coordination with the other components of the healthcare delivery system, but also in the community-based organizations. We know from the other data point we have is that we know that health is also determined where people live. Do they have housing? Do they have access to healthy foods? Do they have transportation? All of those elements impacting the health and health of the communities. These are really critical research elements, so we don't have to go back and question that primary care is important in terms of what we do. You mentioned this a little bit. We also have those state efforts to invest in primary care. PCDC, along with Millbank and Commonwealth, are leading a national work group. You are a part of that, focusing on primary care investment. What do we need to think about in order to have that right target to invest in primary care? And you shared the data that we're not there yet. Having those primary care working groups, determining what primary care investment is. The states that are joining this focused effort are growing every single day. Arkansas just recently announced forming a task force to talk about what primary care investment should look like. This after years of bringing forth multi-payer collaboration focused on primary care and primary care payment models. So really, it's an opportunity for states to take their assets and really move the ball forward related to policies and levers to support primary care. We're also testing new payment models and care delivery models all the time. We're bringing the lessons learned back into the system. One thing we know is fee for service doesn't help primary care deliver comprehensive care. Those 4 Cs that Barbara Starfield described. So looking at different models aligned with states and also federal initiatives that can really bring primary care into the fold and maximize the value that primary care can bring. Lastly, I would talk about, there are other things I can talk about, but we don't have 3 hours today, but integrated care models, thinking about how primary care and behavioral health come together to really surface patients. You shared, mental health concerns are on the rise. There's a stigma to seeking care. So if behavioral health needs, mental health needs, substance use disorder needs can be managed within primary care, that's a one-stop shop for individuals who in many cases have a lot of reasons why getting to the doctor is a little bit difficult. So making it easier, making the right thing the easy thing is really critical, important. In those models as well, thinking about oral care, stopping us from separating our mind, our teeth, our body from really delivering whole person care. I happened to be in Virginia last week with a behavioral health organization and an FQHC. They were starting their journey of thinking about how do we truly deliver for our community integrated care, thinking about where's the location, what training does our staff need, how do we bring these two disciplines together and have them work effectively, because the language is really different, and how the different disciplines are trained are really different. But models show that it can be done. Also bringing in the administrative functions like billing into the process as well. We have both operations, we have both clinical care, we have resources in the community. How do the two organizations come together and really create that integrated care model that will be a benefit of the community.
Excellent, excellent. So much to think about there. And I'm glad that you brought up the fee for service. And I think I intended to do that, but I'm glad that you brought it up. It was going to come up sooner or later. And um, uh, the next phase is really to talk about things that are not working from your perspective. But it is very clear that the fee for service, which is still the predominant payment model in this country, despite many years of effort to move more towards a value-based payment model, we're just not making the steady progress that we would like to see. Now, clearly, Medicare is a different entity, and Medicare is really essentially being pushed along to increase the percentage of their value-based payment. But I would like to hear more of your thoughts about that. It's very clear too that we again, this is something we've known about. We've known about for a long time. The value-based transactional payments work for some specialties. They work fine for some specialties that are more transactional. We are not like that. And it's very clear if COVID taught us one thing, and it taught us a lot of things, it's shown a very bright and very unfavorable light on the fee-for-service model. And all you have to do is read the Green Center reports that they did every 2 weeks during the pandemic. It is desperation. I mean, these are practices that have no safety net whatsoever and can't see patients. But yet, and this is part of the beauty of primary care, they figured it out. They figured out over a weekend in some places how to do telemedicine and how to do immunization clinics. So, but I would like to hear, because I want you to talk about what you see as not working, but maybe that's a good way to start is the payment model. What in your view is the problem with the payment model?
Sure, and just to one comment around COVID, I think you're absolutely right. We saw that primary care was able to pivot, putting in telehealth programs on a dime to be able to surface and service the needs of the community, setting up shop in the parking lot. These are the stories and the epitome of what primary care is. And the reason why fee for service isn't working is because you're paying for a widget. If you only pay for one thing, then you get one thing. And primary care is so comprehensive that the payment models need to really truly shift to payment models that allow the flexibility of a primary care practice to meet the needs of their patients and the populations they serve in the flexibility because different communities have different needs. And also then outreaching to the community as well. So you talk about what's not working. There's a statement that we have in the improvement world that every system is perfectly designed to get the results that it gets. And I think that's true for healthcare as well. You mentioned this a little bit earlier that for the United States, we spend more on healthcare than any other industrialized country, but we don't see the correlation to value or quality. And that's a problem. And, I think the reason behind this is we're all starting to realize that our health and care system is really a sick healthcare system, and we need to start shifting it to be that health and care system. So what do I mean by a sick healthcare system? Really, it's a system that focuses more on sickness versus investing in prevention and wellness, kind of stopping chronic disease before it starts. Why is that important? Why is this happening in our healthcare system? Well, there's something called profit. I mean, sick care is profitable, and we have a healthcare system that focuses on making a larger profit, making a profit year over year. It's not hard to see why this happens. America is built on capitalism. We take pride in that. But it's time to probably start thinking about that that's not really working in healthcare, though. We need to come to terms with this and start to drive a system that invests more in prevention and wellness to decrease the prevalence of disease. This is going to be a tough nut to crack. I think we're starting to see that more. It's something that the current administration is talking about, moving towards prevention and wellness. So this may be our opportunity in a time where things are rapidly changing. We may be able to find a way forward to think about how do we shift our funding and support and investments to prevention and wellness. Another element that I would say is not working as well as we would like to see it work is that primary care doesn't have one common voice in communicating about policy levers that are needed. There are really great organizations that are focusing on primary care. But there was a recent talk about research and research from the Larry Green Center. They recently did research that showed that the public is incredibly supportive of primary care, but they also think that primary care makes 10 times more than really what they do. So we have a significant difference in perception about what primary care is paid. And based on the fact that the public is incredibly supportive of primary care, we need to start talking about what those levels of investment and payment really need to be in order to achieve the value proposition that primary care brings. I mentioned some of those, the really wonderful organizations that work on messaging related to primary care and the research related to primary care. American Academy of Pediatrics, American College of Physicians, American Academy of Family Physicians, advanced practice organizations for nurses and physician assistants, the Primary Care Collaborative. In many cases, these organizations are working together to align the message, but if it's delivered by different organizations, policymakers are getting lots of messages, and they may not feel that the message is aligned. And policymakers do believe in primary care, but may feel if they're getting messages from all of the organizations supporting primary care that maybe they're picking one over the other. And I think it's an opportunity for us to step back and think about how can we communicate more effectively? How can we assure that the policymakers, our communities are understanding what's really going on with primary care and where the opportunities are? Otherwise, our policymakers who are working very hard, if they feel like they're getting different messages, it'll lead to inertia, lack of progress towards primary care policy. Lastly, we have had the change in the administration. You mentioned that earlier, and that is a dynamic. There are some really solid programs and models that have been pulled back or eliminated. Making Care Primary is one of them. That is an example of a model that had a lot of history behind it. And as it got to its current model, it was really informed by that previous research and what people are asking for. But unfortunately, it's not going to continue. So those are the things we need to think about going forward is how do we make sure as we're looking at efficiencies within the government, which everyone feels, there is an opportunity for efficiency, that we don't throw the baby out with the bathwater and really think about the models that we should keep and uh, that are honestly really supportive of states and moving towards a solid system of primary care.
Very, very well said, very well thought out. So you mentioned CMMI, all right, we both mentioned Center for Medicare and Medicaid Improvement Initiatives and Innovation, sorry. And we met in the early days, the heyday, if you will, of the patient-centered medical home movement. And I think we can call it that. That started late 2007. The joint principles of the patient-centered medical home were published. And it was a pretty groundbreaking thing, really, if you think about it. And 330,000 physicians were represented or something. But if you dig a little, and certainly that's valid, but if you dig a little bit deeper, then you talk to Paul Grundy, the godfather Grundy, who many of you may know is the global medical director for IBM. And Paul, being the astute fellow that he is, saw that the people the IBM employees that were living in different countries around the globe would have better outcomes, different outcomes based on the system. So he really had a unique view, I would say, to say, okay, and I'm not going to use the words that he used, but it was very clear that he did not feel like in the United States of America that IBM or their employees were getting their money's worth, their value. So I say that just sort of as a lead up to the patient-centered medical home. So 2008, 2009, 10, all kinds of demonstration projects. Colorado was one of the first. Rhode Island was one. Pennsylvania. And they really all look different, and that may be part of the challenge in understanding the impact. But I would really like to hear from you, because we've had all this time to look retrospectively, to look at the PCMH, which I believe is still a good model. Now, should it be tweaked? Should it be, adjusted somewhat? Yes. But I'd like to hear from you, Julie, as someone who has really sat in a place where you can see, what did we learn? What did we learn from this fervor of, of creating these models? What did we learn that it needs to be successful?
We learned a lot of things, and I appreciate you bringing up Colorado. We had the opportunity to do the first multi-payer patient-centered medical home payment model. So using the principles of patient-centered medical home and thinking about what is a model for payment, and really that work led to comprehensive primary care, which was a model within CMMI, or the Center for Medicare and Medicaid Innovations. And some of what we learned in the beginning, first of all, that the elements within PCMH recognition really thoughtfully served as a roadmap for primary care practices to think about how they would transform. One of the things Paul would say, this isn't nibbling around the edges, this is really transformation. What we had when patient-centered medical home was rolled out, though, was we did have a disconnect in terms of the payment models being there to be supportive. So in some cases, it ended up being an unfunded mandate. In other cases, it was funded, and some of those models are still in place today. New York uses PCMH as a model for being able to provide additional funding to primary care practices who are serving Medicaid members. And it's a fantastic model. And it really creates alignment in terms of delivering on what we're now calling advanced primary care and high functioning primary care. The other thing we learned in those models is that multi-payer is really critically important. Um, Primary care practices are going to do the right thing for all of their patients, whether they are getting paid to do the right thing or not. So if all the payers, Medicaid, Medicare, commercial, do not come to the table with a solid payment model for them, yeah, they're going to do the work. And you may say, oh, that's great. But you're doing it on the backs of individuals. You talked about moral injury. It really does become an area where we are creating moral injury. And I don't think in America we promote that people should be doing work that they're not getting, successfully paid for. And that is, another lesson learned that we had. Uh, it was and I would say we still have it, patient-centered medical home for federally qualified healthcare centers. They use it as a recognition program to support developing, quality. the expectation of quality is significant in federally qualified healthcare centers or FQHCs, and they do use the roadmap and the certification of patient-centered medical home to truly support their delivery of whole person care. And as I mentioned, New York still uses PCMH as a recognition process. I think, there's a little bit of a lack of trust among providers that the payment model and the recognition process won't come together, but I don't think we should give up on that, especially as, we're continuing to have conversation about what, states are having those conversations. What should the investment be in primary care? How should we support them? Investment both in different payment models, but also in the ability for primary care to deliver on high value primary care. So there are lots of different ways that you can deliver on that investment. So don't give up on it yet, Sue. I think it is still a good model. Many of the organizations that are providing the recognition or accreditation programs, they also use research to update the process and continue to move that roadmap forward, to assure that primary care has a structure in which they can change the way they're delivering care, transform the way they're delivering care, and truly meet the needs of the community.
I love that, and it's inspirational. And coming from you, for somebody who's really studied this and lived this for so many years, it's really reassuring to hear that you still believe in the model. And I know in the early days, and we had a pilot project in Texas, in North Texas. One of the challenges was data, was
Hmm.
getting the data, and I think that the research does show pretty clearly that if you look at studies, at the practices that had more sophisticated data extracting or ability really did better, which makes sense, right? That they could track things better. And so hopefully, and again, in the 15 plus years since that time, I would hope, despite what I said about EHR, but I would hope that that capability has advanced and can be helpful. And that's a great example where EHRs can be very useful is in population health. And so good. I'm encouraged to hear that. I'm encouraged to hear that you still believe in the PCMH. I'm not surprised, but I'm certainly pleased to hear it. So, gosh, we've covered a lot of things, and I could keep going, and I know you could too. But are there any thoughts that you want to leave with our audience as far as what you think people can do? So we go to a conference and we get all excited about things that we can do, and then we go back to work the next day and reality sets in. So what are some things that people can do? What are some sort of action items that people can do walking away from this program?
I think there are a few things, and again, in the quality improvement world, we call it what can you do by next Tuesday? And in many times, some of what we're talking about has a longer lifeline related to it. But if you set some intention, it really helps to keep the work moving forward. I think, I had some ideas, but as we're reflecting on the new administration and some of the things we are seeing, I'm adding one to my list. I had a list of four. I'm going to add a fifth one. It is really thinking about some of the models that over many different administrations have really honed in on primary care and how to be supportive of primary care. One of them is healthcare extension work. It really comes, it's a model that was written, and or identified within certain statutes, but really comes from agricultural extension centers. And I grew up in Nebraska, so I know agricultural extension centers, and thinking about how can states create a structure to be supportive of the delivery of primary health care. So not only primary care, but public health as well. And there's been some models within the Agency for Healthcare Research and Quality, ARC, that have led up to putting out a grant opportunity called the Healthcare Extension Model. Many states submitted their application around the holidays this past year, and the great news about the model is it has funding. Not many models can say that, but through the trust fund, it has funding. It's a little uncertain how it will move forward, considering some of the restructuring that's happened. A, AHRQ will be in the Office of Strategy, but I think it's incumbent on all of us, especially the states that submitted their application, to have conversations with their leaders in the community to talk about the importance of this work. It really was a model to support the assets of primary care, to develop healthcare delivery in communities. It allowed states to define what that looked like and use the assets that are available to them. So really had an incredible structure to it. So I'll step off that soapbox and go on to a different soapbox of several things that we can think about as we move forward, and everyone will have to think about what they can do related to their respective roles. But some of the investing we need to do, reforming payment, so private providers can deliver on right care that's right for the patient at the right time. These are phrases we've been using for a long time. We still need to work towards that payment model that actually allows primary care to be able to do that. The other thing we need to think about is increasing the reimbursement for primary care. Why? It's not just about making more money, but it really supports primary care, delivering broader set of services. We talked earlier about non-medical determinants of health. Primary care in communities, both rural and urban, are so well positioned to be supportive of the patients within their practice, to look at those non-medical determinants of health. But this is something newer in the realm of the work that we do and isn't built into current payment models. So we need to think about when we're asking primary care to do additional things that are great for them to do, how will we pay for those services? The next thing, third thing on my little wish list is investing in that primary care infrastructure. How might CHWs be a part of that care delivery team, community health workers? You mentioned technology, and we could probably have a whole session on technology. And I agree with you, technology should be in service of delivering healthcare, not the other way around. But technology can be really expensive. So, how do we look at some of those, building the infrastructure, using the assets? Many states have health information exchange. How can we align some of the assets within the states, the data that's available, and make sure that it's available to primary care so they understand their population, they can actually deliver on care that's meaningful. Lastly, I would say we have to work on that primary care workforce and pipeline. It's a tangential but incredibly important space that we have individuals who want to go into primary care. And to your point earlier, individuals who want to practice in the communities that they grew up in. There's nothing more valuable, and research actually supports it, that having a primary care provider that has grown up in the community, that knows the community, that looks like the members of the community, is incredibly important. So those are my top five that we should all be considering as we continue to support and promote primary care going forward.
Wonderful. Julie, this has been such a delight, and we are so grateful for your sharing your knowledge and your wisdom so generously with us. And we look forward to continuing to improve and deliver on our vow for primary care that we both hold so dear and has such an important place in our lives. So, Julie, thank you again for everything. Take
And
care.
thank you. And thank you for surfacing this incredibly important topic.